PTSD, it's my view that PTSD, which obviously symptomology is different, it presents differently than CFS and fibro, but I don't think it's just a precursor. I actually think it's the same illness. It's on the same spectrum in my point of view.
PTSD is one part of the energy drain.
Yeah.
And it reflects in its own ways, but it is common and needs to be addressed. In the new edition of From Fatigue Fantastic, we talk about autonomic resetting and hypothalamic resetting. We talk about the chapter just on treating PTSD.
You get traumatized. A large part of your mind is always ready to go, like, when will it happen again? And are they going to do it? And can I trust myself? Because I cannot trust either my own system or the people around me.
Okay, but you're articulating the problem through the language of the kind of prefrontal cortex, if you like. You're saying, I'm thinking this, I'm thinking that. And it is a problem of time. But your book is called The Body Keeps the Score.
Yeah.
And I think that there's more to the story, because it's not really just that there's a sort of cognitive expectation. You can't easily defeat it by a cognitive reframing, because there's something deeper going on.
Exactly. So you know, as Westerners, we think that we're rational human beings. Of course, our history completely contradicts that we're rational human beings. When we have been brutalizing each other and doing terrible things to each other since time immemorial, we are rational people and we can work things out. And that when we think that we are in charge of ourselves and can control our behavior. The reality is that about 3/4 of our brain is in the back of our brain that we have basically no control over, and that's in charge of your body. We have a brain in order to steer our body and take care of our body. And so at some point, you need to go to the bathroom. You can say to your primitive brain, don't be stupid, don't waste your time going to the bathroom. But when you need to go to the bathroom, you need to go to the bathroom. And when the primitive brain says, I'm hungry, I need to eat, before long you have to eat. And if you have to sleep, you have to sleep. And you have to breathe. And so basically the whole big part back of your brain is there, just like your dog and just like your cockroach, is there to steer your ways through the world. And then as humans, we got a little frontal lobe on top of it to explain what we do and to understand what we do. It's a marvelous part of the brain. I wouldn't knock it at all. But the problem is that if you, let's say, like Benjamin, if you happen to have been molested by somebody who has a Dutch accent, now you talk to me and you feel threatened and angry, triggered by my accent. Say to yourself, don't get angry with the guy, don't get freaked out by him, because he's a reasonable guy with a funny accent. But the back of your brain is impervious to that rational stuff. And you will have that intense reaction to, let's say, my accent, or any number of things. And much of the time, your frontal lobe will not even be able to understand why you freak out so much.
People with ME/CFS, fibromyalgia, POTS have a lot of limitations. Learning new
diseases of traumatic stress. Pat had been involved in a relatively minor but particularly terrifying auto accident. While stopped at a light behind a large dump truck, the truck unexpectedly began to back up. Unable to retreat due to the car behind her, and apparently unseen by the truck driver, she watched in horror as the truck slowly bore down on her and crushed the hood and engine compartment of her car. Her car was shaken but not moved, and the noise of the crushing of metal finally prompted the truck driver to stop. Pat was predictably shocked, stunned and numb, and took hours to recover her senses and awareness of what had happened to her. She subsequently developed headaches, neck pain, panic attacks, and full-blown post-traumatic stress disorder. along with significant cognitive problems. Within a week of the accident, she developed influenza, with a severe eruption of herpes sores on her lips. She missed her next menstrual period, and within 6 weeks gained 12 pounds, with most of the weight embarrassingly concentrated about her waist. Several bladder infections followed in the ensuing months, and heartburn and symptoms of gastroesophageal reflux prompted a diagnostic workup by a gastroenterologist, with negative results. As her neck pain worsened and spread to her lower back, shoulders and arms, she noted increasing morning stiffness and generalized pain and sensitivity to touch. With the development of interrupted non-restorative sleep and chronic fatigue, she was ultimately diagnosed by a rheumatologist with fibromyalgia, chronic fatigue syndrome, and irritable bowel syndrome. The pathophysiology of stress. The concept that prolonged or excessive exposure to stress could contribute to the development of specific diseases was formulated by Selye in 1936. His original studies are mentioned in Chapter 2 and have led to the conclusion that exposure of an animal or a person to a variety of stressors would result in a complex neuroendocrine response primarily involving the hormones of the pituitary gland and adrenal cortex. These responses were critical to the survival of the organism when subjected to an acute stress, but exposure to prolonged or cumulative stress could result in damage to the organism. Stress versus trauma. Prolonged stress and trauma, although they are basically part of the same continuum, differ in a number of ways. Stress may be defined in one sense as any negative stimulus that produces persistent activation of the sympathetic nervous system and related HPA pathways. Trauma may be viewed in this light as an extreme form of stress, one that has assumed life-threatening proportions. Trauma also is usually a sentinel event or events of great threat and magnitude, producing a maximal arousal fight-flight response. Also, the neurophysiological effects of trauma will often not occur unless there is an element of lack of control or helplessness associated with the stress. When relative helplessness is present, an experience of terror or horror may accompany the traumatic event, an emotional state that is very suggestive of elements of the freeze immobility response. Once again, the combination of a life threat associated with helplessness is the prerequisite for trauma to occur. The freeze represents a temporary adaptation to acute stress that is not physically sustainable, and one that is certainly not associated with continued arousal associated with adrenaline and elevation of serum cortisol. As we have noted, the freeze response very likely is associated with the perceptual state that we call dissociation, an event that is a powerful predictor of subsequent development of PTSD in individuals subjected to a traumatic experience. Traumatic stress and the development of PTSD are not inevitable with exposure to stress or trauma, however life-threatening. These events very likely depend on the event of the freeze immobility response occurring in a state of helplessness associated with the threat, and perhaps on the perpetuation of dissociation as a secondary event. By definition, they also depend on the absence of a freeze discharge. As a result, we might expect to see a substantial difference in the pathological changes in the body, and therefore the diseases that occur in chronic stress, trauma, and traumatic stress. The diseases of trauma. Chronic pain. One of the most thoroughly studied symptoms associated with prior histories of severe trauma is chronic pain. Many of these studies address the effects of childhood abuse on chronic pain complaints, especially in women sexually abused in childhood. The baseline incidence of childhood sexual abuse in women has been estimated at anywhere from 12 to 64% of the general female population in various studies. An average incidence probably falls somewhere around 30%. In males, the incidence is predictably less than half of that figure. Many studies document the association between childhood physical and sexual abuse and chronic pain. Perhaps the most thoroughly studied association is found between female childhood sexual abuse and chronic pelvic pain. In general, these studies show a significantly higher incidence of childhood sexual abuse in women with medically unexplained pelvic pain than controls or comparison groups such as women seeking tubal ligation. Other studies, however, show that childhood physical abuse predicted all adult pain syndromes as well or better than sexual abuse. Taken together, childhood sexual, physical, and psychological abuse are powerful predictors of chronic pelvic, abdominal, low back, orofacial, and myofascial pain. Myofascial pain. Much of the neck and shoulder pain persisting for 6 to 8 weeks after MVA is believed to be attributable to myofascial pain. Myofascial pain, of course, is a common condition found in many types of injuries and also notably triggered by life stress. Common tension headaches are due to stress-related myofascial spasms in head and neck muscles. In fact, probably the most common cause for chronic headaches, neck and low back pain is myofascial pain. In whiplash, it may persist for months and even years. Even after it subsides, it may recur in the same muscle groups with uncanny persistence with ordinary life stress. There you have it. I have had the opportunity to follow a few patients over periods of 15 years who experienced up to 3 MVAs during that time. Even after the third accident, patterns of myofascial pain, spasm, and trigger points related to the first accident continue to be prominent and apparently selective for the same group of muscles. Some practitioners of body therapy, such as chiropractors, physical therapists, and massage therapists, call this body memory. Described by a number of researchers in the late 19th century and the early 1900s, myofascial pain was initially called fibrositis or myofibrositis. From its earliest description, it has generally been attributed to a sudden violent strain of muscles, ligaments, or tendons, or in some cases to extended overuse of the muscle-tendon unit. Clinical features include tender areas in muscles that contain isolated, taut bands of muscle fibers. One can actually feel hardness of a small area within these taut bands that is exquisitely painful. These areas of unique tenderness, when compressed, refer pain to a usually predictable distant site based on which muscle was being palpated. These painful spots were first called trigger points, and the name myofascial pain was applied to the condition in 1952. Over the years, clinicians have discovered that injecting saline or a local anesthetic into these trigger points not only would consistently produce predictable referred pain to another specific area of the body, but often would turn off the trigger point and its associated muscle pain for variable periods of time. Autonomic characteristics of trigger points include constriction of blood vessels, sweating with increased electrodermal response, pilomotor activity, goosebumps, and dermatographia, persisting redness when the skin was scratched. These findings suggest that autonomic regulation of blood vessels is distorted or impaired in the affected area, possibly leading to ischemia or impaired circulation. Early biopsies of trigger points reveal subtle changes in mitochondria or adenosine triphosphate (ATP), cellular organs of energy, with mucopolysaccharide complex sugars, deposition and sarcolemmal muscle fiber disruption. These findings were suggestive of deterioration of muscle fibers due to impaired blood supply, perhaps related to increased metabolic demand in the face of reduced circulation. In summary, these studies suggested the possibility of impaired circulation and altered autonomic control in the smallest blood vessels that supply nutrition to the affected muscles. Many of these findings have not been reproduced in subsequent studies, however. Theories of causation have included, among others, an energy crisis involving the muscle fiber dysfunctional muscle stretch reflex fibers, an abnormal attachment of spinal motor nerves, abnormal stretch reflex nerve circuits, and abnormal nerve signals from movement detection nerve sensors in the muscle to the cerebellum, basal ganglia, and spinal cord. In summary, these theories generally address abnormalities in the organization of motor reflexes within the spinal cord and unconscious reflex centers in the brain that control movement. These theories are guesswork at best. Myofascial pain appears to be a chronic, self-perpetuating condition that is remarkably resistant to treatment, is often regionally specific, and in some cases may last indefinitely. Many physicians believe that myofascial pain may be the most common reason for patients to seek medical attention.
And especially in the context of ME/CFS and fibromyalgia.
So why are we talking about neuroplasticity for these particular illnesses anyway?
Well, neuroplasticity is really all about how the brain can change. Now, in POTS, for instance, it's widely recognized that the illness is caused by dysautonomia, by dysfunction of the autonomic nervous system. But with ME/CFS and fibromyalgia, we're only starting to come around to this view now in the wider medical community and research community. So really, if you even go back to when CFS Unraveled was published, and you looked around most of the websites, it was considered a complete mystery, whereas now people are recognizing more and more it's a neurological illness, which is a little surprising because the World Health Organization actually classified chronic fatigue syndrome as a neurological illness, I think, goodness, going maybe back as far as the 70s or 80s.
Yeah.
And so if the problem is with how the brain is functioning, or how the brain is behaving, to create these really upsetting symptoms, real physical symptoms, the question is, well, how can we fix that? And the answer is neuroplasticity.
So what are some specific ways in which neuroplasticity can occur? It doesn't just spontaneously happen, obviously.
Yeah, sure. That's a great question. Well, I guess the first thing is we need to probably have a look at what exactly is neuroplasticity specifically. So it can occur in two ways. It's either through growth. This is known as neurogenesis or structural neuroplasticity, or it can be a functional change. So that's where the neurons in the brain learn to behave differently, or they connect differently, which is referred to as cortical remapping, or also as functional neuroplasticity. So those are the two main ways, and this was actually proposed a long time ago that this occurs. I think it was back in the late 1800s by a famous American psychologist, and that was the first time that we heard that this concept of neuroplasticity. So yeah, your question was, so how does it occur? It doesn't just happen in its own right. Well, actually it does. It does happen in its own right. Because neuroplasticity is basically what occurs when we become ill. And it's just neuroplasticity working against us to create this maladaptive stress response. And another example is chronic pain. Chronic pain is basically a maladaptive reorganization of the nervous system, and it actually causes physical changes in the brain. So it can actually cause a reduction in the gray matter in the brain globally, as well as in some specific regions, including the prefrontal cortex and the right thalamus. And those are interesting areas of the brain, and they come up often when we're talking about recovery from this illness as well. So that's how neuroplasticity can occur when it's working sort of randomly, working against us. But with a more focused approach, we can also have positive neuroplasticity occurring, and that's through brain training or neural retraining. And that's basically an application of focused exercises and training to create changes that we desire.
So, clearly.
Somatic responses to stress. At or even before the moment of impact of two automobiles, the occupants' brains undergo a predictable series of changes. Sensory input usually involves visual or auditory awareness of the impending crash and may have an effect on the content of subsequent memories related to the trauma. In either case, within milliseconds, the thalamus and the amygdala receive a barrage of messages from sensory organs of the head, neck, and body. The sensory messages of threat, with input from locus coeruleus through the neurotransmitter norepinephrine, would trigger the cycle of arousal through the amygdala and other pathways. The hypothalamus and autonomic nervous system will trigger the systemic release of epinephrine, adrenaline, from the adrenal medulla, preparing the body for fight or flight. The body's responses of the fight-flight response are, of course, predictable, but worth reviewing in the context of the accident itself. The eyes will widen, the pupils will dilate, and the eyes diverge, move outward, slightly in order to maximize the field of vision. The pulse, systolic blood pressure, and cardiac output will markedly increase to provide oxygen and glucose to the brain, heart, and muscles. Skeletal muscles will contract and exhibit increased tone in preparation for action or self-protection.
Systolic extinction training. If you have fibromyalgia or a related condition, you've probably never heard of this. Perhaps some of you recognize the name, Professor Dr. Kati Time. So, are we on the cusp of seeing highly effective treatments for the wider global patient community? I loved her story of how she accidentally discovers a treatment during her research. Professor Time and I discuss our concerns around medical research for this group of illnesses, as well as how the role of psychology is misunderstood in the context of healing for what is not a psychological illness, but rather a real neurological dysfunction. You've been a medical researcher for many years now. You've been highly decorated. I know you won the International Fibromyalgia Research Award in 2008. You've won many national awards in Germany. And so your work has been on chronic pain, but at some stage you start to focus on fibromyalgia. And I wonder, why is that?
Fibromyalgia is a very interesting disease for me, because it shows us how stress can influence our body and can change so-called inhibition processes in our body that leads from actually a healthy, very active state to a diseased state. Yeah, so with a high level of impairment, interference, yeah, sometimes low activity, sometimes extremely high activity, because the people don't feel the pain so much when they are in a stress situation. Yeah, and it has so many different phases. It's a very interesting disease.
This variation in how people's body responds in healthy population or in the fibromyalgia population. And I know you did some research looking specifically at the autonomic nervous system dysfunction that people have with fibromyalgia, and you found that it goes into different subgroups, right?
Yeah.
And I wonder, how can we work this out? How can we have the same issue with the barosensitivity reducing and creating pain, even if we don't have high blood pressure? Because some people have low blood pressure, right?
Yeah. So we made a stress experiment, and the stress experiment had two stressors. One stressor is a mental arithmetic, and one stressor was a social stressor. So we asked the patients, what are the problems that you discuss with your partner, and what are the problems that you don't discuss with you? So, and then during the experiment, we have invited the partner too. Yeah, we ask both, what is the reason that you don't discuss this topic in? Yeah. So, and this was an extremely high stressor for all of our patients, because it was so, I mean, actually I could have
confronting.
Bring a lion in the room. Yeah. So, and this was an inappropriate stressor, because we couldn't find any differences between our patients anymore. It was just too much. Yeah. So an experience that social stress is really this what makes us sick. Yeah. So, and mental arithmetic as a performance stressor allowed to find the differences between the patients. And we found 4 different responses. Interestingly, the same responses that we found years before with patients with rheumatoid arthritis and systemic lupus erythematosus as inflammatory rheumatic diseases, patients with hypertension, patients with chronic depression, so more psychiatric disorders, and also in healthy people. Yeah, we have tested astronauts and cosmonauts, so very healthy people. And so it seems these 4 different response patterns are pretty valid in our human responses. Yeah. So, and the most important or the major stress response was the response with high blood pressure, followed by the response with low blood pressure. So, and here we differ between baseline and reactivity, and we see that people can respond with a high blood pressure in baseline. These are clearly our hypertensive patients, and they can also respond with normotensive blood pressure. But as soon as they come in a stress situation, they go up and respond with hypertensive blood pressure responses. Yeah. So, in the second group that you mentioned before, is it so that people can have a hypotensive blood pressure as the baseline, and also a normotensive, but it can go down, yeah, in stress situation, yeah. So, and
right, yes,
and the interesting thing is, it provokes also this kind of stable pressure intensity in the carotids, and that reduces also the baroreceptors, yeah. So, or reduce the activity of the baroreceptors, yeah. Fortunately, we can always awake them, yeah. But as soon as the people is in a stress situation, the procedure is the same. The baroreceptors just sleep.
Baroreceptor reflex. Assessment of baroreflex sensitivity and influencing factors. Baroreflex regulation of pain. Perception. Clinical implications of impaired baroreceptor mediated pain modulation. The central nervous system and peripheral nervous system work in concert to maintain homeostasis in response to psychologic and physical stressors. An ensemble of coordinated biologic processes modulates sensory, emotional, motor, autonomic, neuroendocrine, and immune responses to tissue damage, including surgery. As resting arterial pressure increases, a given incremental change in arterial pressure evokes greater activation of carotid sinus baroreceptor afferents, thereby promoting a greater increase in parasympathetic tone and a decrement of sympathetic tone. This baroreceptor elicited shift in autonomic balance toward the parasympathetic side results in a reduction in heart rate, arterial pressure, and adrenal secretion of adrenaline. An intrinsic pain regulatory system is modulated by both cardiovascular dynamics that influence baroreflex sensitivity and is diminished in fibromyalgia. Baroreceptors relay cardiovascular output to the dorsal medial nucleus tractus solitarius reflex arcs that regulate pain, sleep, anxiety, and blood pressure. Increasing evidence suggests that baroreflex pathways also project to key regions of the central nervous system that regulate somatosensory, somatomotor, and central nervous system arousal. In addition to maintaining autonomic homeostasis, baroreceptor activity modulates the perception of pain, as well as neuroimmune, neuroendocrine, and cognitive responses to physical and psychologic stressors. Unique psychophysiological response patterns were observed in fibromyalgia. Increases in stress levels preceded increases in pain levels, assessed several hours later, but not vice versa. Although fibromyalgia syndrome, FMS, is a chronic condition, its cardinal symptom pain is known to fluctuate over the day. Stress has often been claimed to exacerbate pain. Stress exacerbates pain in the everyday lives of women with fibromyalgia syndrome. The role of cortisol and alpha amylase group 1 shows a hypertone stress response with high pain, anxiety, and pain behaviors. Data suggests that unique psychophysiological response patterns are associated with psychological coping and mental disorders in fibromyalgia patients.
Well, and you know, it is complex, isn't it? And I think that's probably part of the reason why the wider research community, the medical community, have struggled with this illness, because not only is it complex, but the patient community is heterogeneous, right? It's not that everybody is the same. And you know, just before we started, you did mention that there was an interesting difference between the patient groups around the world, specifically in America, how people are trying to get away from the word fibromyalgia syndrome. Can you sort of recount to us what that was all about?
Yeah, I observed a very interesting discussion between the patient self-help group or self-support group in US and in Germany. And in US it is so that the patients say that is fibromyalgia and not the fibromyalgia syndrome, because the syndrome is always something where symptoms are not connected with each other, right? So, and in Germany, the patients say, okay, it's fibromyalgia syndrome. Yeah, I'm actually thinking when you see the global or the central symptoms of fibromyalgia, like sleep deficits, pain, fatigue, and essential impairments like cognitive concentration and memory deficits, they are connected. Yeah, they are actually clearly connected. Yeah, and maybe we can talk later about this connection also.
Absolutely, and I think this is really what connected us in the very first place some years ago. And really, the thing too is like, I mean, one of the things I often see patients saying is, "How can I be so unlucky? You know, first I have irritable bowel syndrome, and I have chronic fatigue, and then I have fibromyalgia, and then I have POTS, and then I have you know." It goes on and on and on. They feel they've got so many different diseases. But absolutely, you can see that when you really look at it, there is this underlying connection between all of them. And I think when people can understand that, it takes a lot of the stress and worry away, don't you think?
Yeah.
Have you found that with your patient education that this becomes a very important part of their journey, is that they start to understand what's going on, that it helps them feel more at ease and more relaxed?
Yeah, because it's always the case that this kind of complexity of symptoms makes the people crazy. Yeah, they think they aren't normal anymore. They doubt in their own perception. Yeah, it must be a very difficult situation. So, and when they learn that all these symptoms belong together and have a clear connection. Yeah?
My belief that patient education is a powerful therapeutic tool has been greatly enhanced. Altering the threat of the unknown by informing and educating the patient changes the body's stress response and promotes healing. The obvious enlightenment experienced by my patients, the gratitude expressed, and the improved response to therapy, resulting from detailed education. Providing them with a rational and comprehensive explanation for their symptoms is strong medicine. Many patients suffer almost as much from the dismissal and invalidation by the medical and insurance industries as they do from the effects of the disease itself.
So we start, for example, in patient education with a very easy question. I am asking, what do you think when you hear that word, pain? Yeah. Then they start with brainstorming what they think about this. Maybe, the pain is something that is disturbing. It interferes my daily activity. I try to lay down, or I'm thinking that is so bad. Why I have this disease? What have I done? Yeah. So, or it's just this kind of sensory description how the pain feels. So, and then I sort all these different answers, and then we see 4 folders, like 4 phone calls. Yeah. So, and each folder is clearly connected to brain areas. Yeah, all the sensory impressions that the pain gives us is connected to the somatosensory cortex, right? So, and all the thoughts are connected to the prefrontal cortex. The emotions that I feel sad or helpless or sometimes angry, is connected to the amygdala or to other centers of our emotions in the brain. So, and then we found out that we have also something else that is actually now in the discussion in the pain field, if that belongs to the pain network, and this is the brainstem. Yeah, and the brainstem is influenced with some components to the autonomic nervous system.
People with ME/CFS, fibromyalgia, POTS have a lot of limitations. Learning new things obviously contributes to our neural flexibility. So given that this community of people with these chronic illnesses can't do this physical activity as much as others, because they end up with PEM, post-exertional malaise, both of us are quite familiar with that. It exacerbates the condition. So can you comment on this a little bit?
You know, Claudia, I mean, it's really always about the details, and sometimes the distinctions between what can be helpful and what can be unhelpful can be very, very small.
Right.
And so it's easy for people to hear some of these things, draw conclusions from them, and do things that could actually be very unhelpful. Mm-hmm. I guess the first thing is, I mean, yeah, physical movement is integral. The brain training that we have in the program also talks about how we engage with our physical body. And this shouldn't be a surprise, because when you look at what we've known about neuroplasticity for a long time, because we've seen like stroke victims recover, or people who've had certain accidents, right, where the part of the brain is damaged. And when they do that, they don't just sit in a chair with a blanket over their legs going, okay, let me start walking in my mind, right? They do the walking in the mind in the sense that they say, you know, leg, move, right? But then the physio will actually move the leg for them.
Right.
So the brain then gets two inputs. It gets the input from your mind saying move, and it gets the input from the body where it is moving.
Right.
And this can then, with appropriate focus, and we'll talk about that shortly, cause these changes in the brain so that we can start to make these connections again. So we have a lot of problems when we have this illness, right? With the brain.
Right.
Like with focus, brain fog.
Yeah.
Difficulty hearing, you know, with stimulation, right? All these kind of things. And with all of these things in play, it can be easy to say, oh, I'm going to work on this. I'm going to get my brain to start focusing. I'm going to do puzzles, and I'm going to, you know, play games, and I'm going to, you know, they have like brain training things on the internet where you can try and make your brain better and stronger. But we've got to understand that you're not like a stroke victim.
Right.
You haven't had the part of your brain die and need to remap your brain or something like this. You have a dysfunction, and the reasons why we have things like brain fog is complex, and it's not necessarily because you can't do it, but because your brain because you're depleted.
Right.
Right. Your brain is not. It's not in a state where it can do this work, and so pushing your brain can actually be unhelpful.
So then, are you saying that you don't think that the illness limits the ability to affect the neuroplasticity in a positive way?
Well, on the contrary, I do think that.
Okay.
But I think we can narrow the reasons for this in more detail.
Okay. How so? Can you explain that?
Well, we have to probably understand a little bit more about how and when neuroplasticity occurs, and how that works. So let's talk about exactly how this happens in the brain. The first thing I would suggest that actually switches on in the brain in order for us to start neuroplasticity might surprise people a little bit, especially the recovery community that focuses on neuroplasticity, right? Mm-hmm. Because what we always do is we focus on trying to calm ourselves, meditation, all these type of things, right? But the thing that actually switches neuroplasticity on is actually adrenaline, or specifically, I should say, noradrenaline in the brain. And that noradrenaline actually brings the brain to a state of focus. And this is very, very important, right? Focus, so remember that. Then there's a second neurotransmitter called acetylcholine. Now this is a very important part of the ANS, acetylcholine. It's actually the primary neurotransmitter of the parasympathetic nervous system. I think it's actually a result, like an output of the parasympathetic nervous system. So it actually is a neuromodulator. It promotes REM sleep.
Okay.
But it's also used in the sympathetic nervous system, right? And obviously the parasympathetic and sympathetic are the two main areas of the autonomic nervous system that we tend to speak about. There's a third part that no one seems to care about.
No, right.
So what happens is that these two neurotransmitters, they come together and they tag those specific brain areas that we're engaging for change. But my understanding is that the change doesn't actually happen then. So it only gets tagged. It doesn't actually create change at that moment. The actual change to the brain and how it functions happens subsequently when we're sleeping. Now, anyone who's got issues, anyone who has this illness will understand that there are some difficulties around sleep.
Yeah.
So I think we can already see the first issue that we might have in creating positive neuroplasticity. But the other issue is also we have to be able to have these neurotransmitters and be able to produce these neurotransmitters adequately. And I think that there are some issues around that which may be contributing partially to the brain fog side of things. So we've got to make sure we've got adequate nutrition and metabolic processes functioning in order to create that. And especially we need to have the essential fatty acids and the amino acids for the production of these neurotransmitters and hormones. So that's what we need, and we need to be able to produce a focus, right? So remember, we have the noradrenaline to create the focus.
Right.
But again, focus is a real difficulty for us, with brain fog.
Right.
Right?
Yeah, absolutely.
So we need the focus, we need the sleep, and that's basically how neuroplasticity occurs and why we might have some difficulty with it.
You just said made me realize that you're kind of backing out from the brain retraining, which comes later in your program. You kind of took steps back because you can't start there. You've got to back up and start. You have to have the sleep in place. You have to have done some of the meditation, right? You've got to have the nutrition in place, the hormones in place.
I'm sure you all know Dr. Georgia Eid. She's a psychiatrist. She has expertise in Alzheimer's and other conditions affecting mental health and the role of nutrition in these conditions. The first time I heard Dr. Georgia Eid speak, it was a recording from a talk from the Ancestral Health Symposium called The Little Shop of Horrors, in which she discussed the biochemical warfare of the plant world. Today, she will talk about the importance of animal-sourced food for the brain. Please welcome Dr. Georgia Eid.
Causes those biochemical disruptions. And these three, kind of the unholy trinity, you can think of these as root causes of just about any disease you're thinking about. Deficiency, toxicity, and metabolic mayhem. So, deficiency, nutrient deficiency is a good place to start. Definitely a root cause of mental illness. So in order to understand how to avoid nutrient deficiencies, we have to understand what nutrients the brain needs and which foods are best at delivering those nutrients to the brain. So the brain is made of mostly fat, about 2/3 fat, and it contains lots of protein, just like every other organ does, and it contains lots of cholesterol. And it also, and those are the macronutrients, fat, protein, because it has a little tiny bit of carbohydrate, and then the micronutrients, which are the vitamins and minerals. And those are there because the brain is an energy hog, and it needs lots and lots of energy. And in order to extract the energy from molecules like glucose and ketones, it needs vitamins and minerals to run those chemical reactions and extract the energy from food. So those are the micro and macronutrients. And it's really clear that we have a problem with maintaining adequate levels of nutrients. Now, I know that there's a lot of controversy about how much of these we actually need, and thank you very much, Amber, for that excellent presentation on this. But I still think it makes sense to wonder why some of us, for example, are so low in omega-3 fatty acids. So these are, if you are, I want you just to notice something here. I think this is the pointer, yeah. So these three, zinc, vitamin B6, and iron, if you're low in any of those, you're going to have trouble making the very neurotransmitters that your antidepressants are trying to boost the activity of. So these are important connections. And of course, another reason why so many people may be suffering from symptomatic nutrient deficiencies, let's put it that way, symptomatic nutrient deficiencies, is because macronutrient quality affects micronutrient availability. So if you're getting your vitamins and minerals from the wrong place, they may not be as effective. So we all in this room perhaps already know this, but meat, contrary to popular belief, contains every nutrient we need in its proper form and without any anti-nutrients to interfere. Whereas plant foods all are missing certain key nutrients, and some of them are in the wrong form and harder for us to use, and they contain anti-nutrients which interfere with our ability to absorb them or utilize them. And there are many, many examples of these, but just a few to call to your attention, particularly phytic acid, which is a mineral magnet that interferes with our ability to absorb minerals, and these minerals are really important for brain function. So phytic acid is particularly rich in the grains, beans, nuts, and seeds, which are the staple foods of plant-based diets. So, but there are a couple of others to call your attention to, carnitine and choline. So carnitine is what's called a conditionally essential amino acid. We sometimes don't, we are able to make it ourselves, but we're sometimes not able to make enough to meet our needs. And in order to make carnitine ourselves, we need these two amino acids, lysine and methionine. And these just happen to be the ones that are the most difficult to find in plant foods. And carnitine is very important for energy balance, as has been discussed before today, and it also regulates the fluid and electrolyte balance in the brain, very important. And choline is an essential nutrient, which is responsible for the integrity of cells. That's something you want. You don't want your cells to fall apart. And it's also important for building the neurotransmitter acetylcholine, which is very important for neuromuscular function, but also in the brain for things like learning and memory. And both of these, carnitine and choline, are easy to find in animal foods, and they're much more difficult to find in plant foods. Now, remember we said the brain contains a lot of cholesterol. Despite being only 2% of the body's weight, the brain contains 20% of your body's cholesterol. But cholesterol is a very big, bulky molecule. It can't cross the blood-brain barrier. So that means that every single molecule of cholesterol in your brain, none of that came from your diet. You can eat a cholesterol-free diet and still have plenty of cholesterol in your brain because the brain makes all of its cholesterol on site. It's that important. So why would the brain go out of its way to make something that's bad for you? It wouldn't. It's really smart. It's a brain. So protein. You can get your protein from plants or animals, no argument there. It's just a little more difficult because all animal proteins are complete. They contain every amino acid we need and in the proper proportions, I might add, whereas most plant proteins are incomplete. Animal proteins are denser sources of protein. You have to eat a lot less to meet your requirements. They're more digestible, contrary to popular belief, than most plant proteins, and they're more bioavailable because, again, the anti-nutrients, etc., protease inhibitors, getting in the way of us extracting all of that energy from food, just like Peter Ballerstedt said earlier. So protein, I think it's important. I think it's easier to get it from animal foods. If you're trying to get it from plant foods, you have to just plan very carefully. And those plant foods come with some baggage. Now, the fat, this is fascinating. So the brain is about 2/3 fat, and you'll notice, let me stand over here. You'll notice that About 25% of that fat is saturated fat, and another 25% is monounsaturated fat, mainly oleic acid, the kind you find in olive oil and lamb. And then the other 50% is polyunsaturated fatty acids, sometimes affectionately known as PUFAs. But no, it's not canola oil up there in your brain. It is these two really, really important essential fatty acids, DHA, which is an essential omega-3 fatty acid, and arachidonic acid, which is an omega-6 fatty acid. So DHA is a really important molecule, irreplaceable in the brain and other parts of the body. It has a special configuration which gives it quantum mechanical properties and that allow it to buffer electricity. So you find it in places where electrons are very busy, places like mitochondrial membranes and the retina and synapses of the brain where cell communication is taking place. So it's very, very important. So you want to make sure you get enough of that. Where does it come from? I want to mention that it's been hypothesized by people who study these things intensely that because DHA is important for the developing cortex of the baby and also for cellular communication connection, that it's essential for higher intelligence. So it's not something you want to skimp on. But where does it come from? Well, DHA is present in animal foods. It does not, plant foods contain absolutely no DHA. Plant foods contain a different omega-3 called ALA, but it's actually very, very difficult for us to convert ALA into DHA, in some cases not at all. So most experts agree that it's important to consume DHA directly, either from animal foods or supplements, algae supplements. It can't be a plant-based supplement like flaxseed, for example, because that has ALA in it. So that's very important to know. And then we have, it may help to explain why people who eat a plant-based diet or even a vegetarian diet have lower levels of these essential omega-3 fatty acids in their systems. Now, what about arachidonic acid? We don't hear about that one too much, but it's really important. So arachidonic acid is an omega-6 fatty acid, and it does all of these amazing things. I've only listed 8 things here. I just ran out of room. And so it's really, really important for your cholesterol metabolism, reproduction, inducing labor, for example. That's important. You don't want the baby to stay in there forever. And the development of the brain, coagulation, endocannabinoids. Those are nice, right? So, so you want all these things, but it's also, for arachidonic acid, it helps with the inflammatory response. And that gives it kind of a bad rap among the plant-based community. They say, well, arachidonic acid, you get that from meat. And so that causes inflammation, so that's bad, so we shouldn't eat meat. Well, first of all, inflammation is really important. We do need inflammation as the first step in responding to injury and infection and things like that. And then the next step is healing. So, you know, I think it's really important to try to fight some of this arachophobia, if you will, with some facts. And the fact is that arachidonic acid isn't just involved with inflammation, which can be a good thing. It's also involved with healing. I mean, it's that complex. So these very simple arguments fall apart under scrutiny. So where do you get arachidonic acid from? There's this pathway in the body which most people still believe functions. Linoleic acid, which is an omega-6 fatty acid that you can get from animals and plants. And it's supposed to convert to gamma-linoleic acid and then to arachidonic acid over here. But the fact is there have been numerous studies that have showed, this is a lovely review article referenced down here if you're curious and you don't believe me, that this doesn't happen in the body. You cannot make arachidonic acid from linoleic acid. So then what are you going to do? How are you going to get your arachidonic acid? You either have to eat animals, perish the thought, or you can get this GLA from certain plant oils like primrose oil, evening primrose oil and borage oil and things like that, or from animal foods. But that's not as efficient as getting you won't get as much arachidonic acid as when you eat the arachidonic acid directly from an animal source food. So for all of these reasons, I maintain that the brain needs meat. That it's, you can try to supplement your way around it, that's your choice, but I think evolutionarily it makes perfect sense that we would need to have eaten meat in order for our brains to have developed, formed, and functioned. So the third root causes I'm going to call metabolic mayhem: inflammation, oxidation, neurotransmitter imbalances, insulin resistance, and there are more than I had time for. But these are another way. So basically, we've talked about why meat is important for the brain and why plants you might want to take a second look at plants if you're having trouble on your otherwise healthy diet. But then how important is it to be in ketosis, for example, or to be careful with your carbohydrate content, or to eat a low carbohydrate diet. And I think this section speaks to the benefits of lowering your insulin levels and improving your metabolic health. So inflammation and oxidation really well established now as root causes of mental illnesses, all of very many different kinds. We often think of mental illnesses as neurotransmitter imbalances, problems with serotonin, which we think of as a happiness chemical. It's much more than that. We think of dopamine as, we associate dopamine with motivation, and we associate dopamine with pleasure. And then these neurotransmitters, which some of you may not be familiar with, glutamate and GABA, they're actually the most prevalent neurotransmitters in the brain. They're widespread, and they are, you can basically think of glutamate as the brain's gas pedal, and you can think of GABA as the brain's brake pedal. And it's the balance between these two that determine how active, overactive, or underactive the brain is. So yes, it's true, there is some truth to these neurotransmitter theories. The dopamine one is fairly strong for psychosis, for example. The glutamate GABA one is really gaining momentum in depression and psychotic disorders and bipolar disorder. So yes, there are neurotransmitter imbalances, but again, what is causing them? So this is one of my favorite pathways to walk through. So this pathway is called the kynurenine pathway. And don't be afraid. So this is tryptophan. This is an amino acid. We get this from protein. And that's how we make serotonin, for example, and also melatonin down here. But serotonin, which is one of the chemicals that helps regulate our mood. And normally, a small amount goes down to make serotonin, and the rest of the tryptophan, under normal, like Zen circumstances, will go down this kynurenine pathway and kind of be equally divided between glutamate inhibition, keeping that brake pedal on, and the gas pedal over here, glutamate activation. And it does all kinds of other things too, which I've eliminated for the sake of simplicity. So that's Zen, your Zen state. But what happens if you introduce a lot of stress or oxidation or inflammation? We know that refined carbohydrates and seed oils, for example, which are staple foods of the modern processed diet, they're in every processed food in the grocery store. That they're powerful promoters of inflammation and oxidation. So if you are under those circumstances eating that way 3, 4, 5, 6 times a day, you've introduced this new element. And the effect that has on the kynurenine pathway is really profound. What happens is you get this thing called tryptophan steal. And instead of enough of the tryptophan going down to make serotonin, it gets shuttled more towards this pathway, way down here, towards the glutamate activation. Pressing that gas pedal, you get up to 100 times more glutamate than you're supposed to have. And it's a huge, huge influx of, you get flooded with glutamate. And up here, glutamate inhibition, the GABA goes down, and you even get a little bit more dopamine up here. So now you've got serotonin, dopamine, glutamate, and GABA all unbalanced because of what you're eating. And, this is something that you really can't fix with medication. But worse than that, when you have all that, when you're flooded with glutamate, it's not just that, okay, maybe your brain's going to be in overdrive for a little while you recover from whatever you just ate. It's also that high levels of glutamate cause brain damage, profound, widespread brain damage. It decreases the level of this really important brain growth factor called BDNF, brain-derived neurotrophic factor, which is responsible for something called neuroplasticity. Neuroplasticity just means how well your brain copes with and responds to and recovers from stress, which, you know, that's something that so many people now are struggling with. Lots of people have stress. Stress is kind of a normal part of life, but how many of us are actually able to recover from it and move on? Then it shrinks the hippocampus, the memory organ inside your brain, and it injures proteins, lipids, DNA, and mitochondria. You get mitochondrial damage every time you get a glutamate burst like that. And really importantly, it damages the blood-brain barrier. So you really don't want this to be happening. This is your brain being damaged from the inside out by eating the wrong way. So we also know that eating the wrong way can lead to insulin resistance, chronically, persistently high insulin levels. And this is emerging science, but we know that, for example, people diagnosed with schizophrenia, before they ever take an antipsychotic medication, are much more likely to have insulin resistance than somebody else will. And you know the antipsychotic medications, they can cause insulin resistance. But this is even before they've taken an antipsychotic. So we don't know if there's a cause and effect relationship there, but it's an interesting association. We know that people with bipolar disorder, if they also happen to have insulin resistance or type 2 diabetes, that they are more likely to have chronic symptoms, they're more likely to have rapid cycling mood, a worsened course, and they're less likely to respond to the mood stabilizer lithium. So that's suggesting that insulin resistance isn't just an innocent bystander in bipolar disorder. Insulin resistance is playing a role in at least the severity of the disease, if not the actual underlying etiology of the disease. And so with insulin resistance and depression, the information is actually much weaker. Depression may have a lot more to do with inflammation than insulin resistance. We know, for example, that these drugs called PPAR gamma agonists, which help with inflammation, but they also help with insulin resistance, they can be very effective in studies of people with even treatment-resistant depression. And they're not standard antidepressants. They don't address neurotransmitter imbalances. But we also know that pure anti-inflammatory medications of certain kinds can help depression as well. So we know there's a strong inflammation component in depression, and that any food you eat that causes inflammation could make you feel depressed right away. So now we've known for nearly 100 years now that bipolar disorder, that you can treat epilepsy with a ketogenic diet. Take most of the carbohydrate out of the diet, and you can stop seizures in their tracks. So if that's not proof enough that carbohydrates affect brain chemistry stability, I don't know what is. But, bipolar disorder and epilepsy have a lot in common. They share a lot of underlying mechanisms, and as a psychiatrist for many years, I've prescribed, and I'm not the only one, most of us do this, prescribe anticonvulsant seizure medications to treat bipolar mood disorders because they're so similar. And so one of the many things that they have in common is that they both, you tend to see higher levels of sodium inside brain cells in both conditions. And the ketogenic diet and the anticonvulsant mood stabilizers, medications like Depakote and Topamax, those kinds of medications, they lower sodium inside brain cells. They remove some of that sodium and put it outside the cell. Now, the reason why that's important is because too much sodium inside cells makes them too reactive. And if you lower sodium, then they're less reactive. So it has a calming influence, stabilizing influence. So, ketosis could be important for all kinds of psychiatric disorders. We've talked a lot about these root causes of mental health disorders. So, if you were a drug-minded researcher, or if you really into nutraceuticals, you could look at each one of these, and this has been done. Just Google it. Every single one of these, you can find a drug or nutraceutical that will help you with this, some strange extract or some expensive drug. You can take antioxidants, you can take anti-inflammatories, you can take ketamine for your glutamate dysregulation. That's a really hot drug right now for depression. But I think and people get really excited about those options. They're like, oh, we figured out what causes this. Now we just need to add something to our bodies to undo it. But what I get really excited about is that every single one of these root causes can be addressed with a ketogenic diet. And so this has been shown in study after study over the years. So sort of one-stop shopping. If you address the underlying metabolic mayhem, then everything else could potentially fall back into place. Things like autism and bipolar disorder and psychosis and Alzheimer's disease responding to ketogenic diets. Now the science is early. We don't have enough studies. We need more. But you don't have to wait for the studies if you want to feel better. You can just try it.
So it's kind of led me back to the beginning of your program and how you sequenced it so brilliantly, and that you've got to do it step by step in order to build. It's like building blocks. You're setting the stage for the neuroplasticity, basically.
That's right. And look, obviously we don't know exactly. I wouldn't be saying, hey, if you don't change your diet, you're not going to be able to affect neuroplasticity.
Right.
But let's make it easy. Let's make it as, let's support our brain and our body as much as we can to be functioning, to be able to recover. And the meditation and the way we do the meditation is specifically designed to allow you to engage in the brain training exercises. So both from we can see that there is, physiological or physical neural, brain changes that are involved that should support our recovery, right? Like from that study I mentioned earlier from Harvard, but at the same point, it's actually the skills that we learn from the brain training of meditation that we can then transfer to the actual brain training. So meditation on its own, I think, is really unlikely to get anyone to recover from this illness.
Well, I know that because I was a meditator for many years before I started your program, and nothing changed. So
that's right. But it's interesting to see that when you look at some of the fast recoveries, yours was, I think, I would say an atypically fast recovery. 90 days. And there have been other people like this, they're like housebound for 30 years, and then 90 days later they're hiking in the mountains, and you're kind of like, really?
Yeah.
It seems a bit unlikely, doesn't it? But when you actually look at the history, you'll find that they actually have been meditating a long time. So when they almost kind of skipped over part of the program and went straight into the neural training portion, and were able to do it very effectively. You also mentioned, I guess earlier, about the different activities you were doing. I think they have multiple benefits. One of the things we really need to look at in our recovery is morale.
For sure.
And like when you were doing these things like painting or some Tai Chi, it's a positive thing. When we're just wasting our lives, that's how it feels, right? For many of us. Not all of us. It felt like that for me.
It definitely felt that way for me.
Then it's very downtrodden, and all of this even this recovery work, it takes effort. It's not easy when you're unwell.
Empowerment is the ultimate goal of all trauma therapy. It removes the state of helplessness that is essential to the trauma experience. Empowerment may be accomplished in many ways, including intentional, symbolic replication of the defensive movement patterns that accompanied the traumatic event but were truncated by the freeze. This is accomplished unconsciously through assessing the felt sense in somatic experiencing, and intentionally in a number of other somatic techniques, including dance, balance, equestrian, and art therapy. The ritualistic affirmative statements of TFT, EFT also may function as tools of empowerment. Finally, providing a conscious cognitive structures of the meaning of the contents of the dissociative capsule after its components have been extinguished empowers one with the knowledge that occasional recurrence of somatic symptoms reflecting the capsule is actually an event from the past. Nevertheless, the field of trauma has yet to solve the dilemma of the cascade of often somatic post-traumatic symptoms that persist long after the criteria-based symptoms of PTSD have subsided. The concept of the dissociative capsule provides a holistic model that reflects the content of the late post-traumatic experience and begs for a novel approach to its resolution through the use of techniques that address the feelings of the body. Although EMDR has achieved recognition after years of exhaustive study, the esoteric nature of most somatically based techniques has relegated them to the dustbin of accepted trauma therapy, despite their widespread use in many parts of the world, and the many uncontrolled outcome studies that reflect positive results. We may have at our disposal therapeutic techniques that ultimately promise the quality of healing trauma that we have yet to achieve. Eye movement desensitization and reprocessing, EMDR. In 1989, Shapiro discovered quite by chance that rapidly moving one's eyes while thinking of arousal-based memory lessened the anxiety associated with that memory for a prolonged time. The discovery was made as part of a personal experience, and as a psychotherapist, she began to apply a technique that she developed from this experience on her patients with PTSD. Result of anecdotal studies documenting the apparent efficacy of EMDR began to spread throughout the psychotherapeutic community, and hundreds of therapists have received training in the technique through workshops developed by Shapiro. The recognition that the body plays a critical role in the manifestation and perpetuation of trauma may be a potent avenue for accessing and extinguishing the core physiology and content of the dissociation capsule. Somatic experiencing, SE. The technique of somatic experiencing developed by Levine for the treatment of trauma led me to my interest in PTSD and ultimately to this book. Somatic experiencing has had far less application than EMDR and has not been subjected to scientific scrutiny. SE is unique and intriguing in that it does not rely on specific cognitive elements to achieve its effects. Levine's theory of trauma uses the animal model of the fight-flight-freeze response in the wild. He notes that when animals can no longer escape a predator, they enter a freeze or immobility state, during which the high-level metabolic and neurochemical energy of the flight response continues despite the immobility of the freeze response. If the animal survives, the stored energy is dissipated through various stereotyped somatic and autonomic responses, including trembling, perspiring, and deep breathing. Human beings tend not to dissipate this energy, possibly through acculturated SE presents another interesting approach to what we know about neurophysiology of trauma. Its primary appeal may lie in its non-cognitive approach to what is primarily a subcortical, limbic, and brainstem phenomenon, assessing and eliciting a motor response linked to a kindled limbic event in a benign environment, and completing the response successfully could exert a powerful effect on down-regulating these sensitized and kindled subcortical circuits, most specifically the amygdala. Levine believes that one does not need to access explicit memory for the core traumatic event for SE to successfully discharge the traumatic energy, although at times it may be useful adjunct to facilitating the technique. The risk of flooding, including the recovery of unremembered traumatic events, is moderate, hence the use of pendulation by the therapist. In general, SE appears to provide remarkable control of the therapeutic process. My clinical impression, based on experience with several hundred patients treated with both SE and EMDR, is that SE tends to result in resolution of dissociative traits and behaviors more effectively than many techniques. I am also extremely impressed with the safety and efficacy of SE in the common problem of the traumatized patient with chronic pain. Myofascial pain is ubiquitous in the chronic pain population and extremely resistant to treatment. Based on my theory that myofascial pain reflects procedural memory for regional muscular bracing patterns experienced at the moment of a life-threatening event, one might suggest that uncoupling of that memory from associated kindled arousal might mitigate the pain. I would prefer to use the term extinction to that of uncoupling, realizing that replication of the motor patterns of self-defense in the absence of arousal linked to the amygdala would extinguish the associated procedural memory for the movement pattern. This concept is in keeping with the theoretical basis for SE, and indeed I have found in many patients that chronic pain, especially myofascial pain, may show striking improvement or even disappearance as part of the SE therapeutic process. Neurofeedback. During the 1960s, a group of behavioral scientists began studying a method of training unconscious physiological processes by measuring these processes and feeding the data back to the patient. The term biofeedback was ultimately applied to these techniques, and the measures fed back to the patient included muscle contraction, hand skin temperature, and galvanic skin response, a measure of perspiration, and brain waves. Auditory or visual measures of these processes were provided for the patient and provided documentation of the state of the body that they were trying to manipulate. With practice, they could learn to relax muscles increase skin temperature, and reduce perspiration in the hands, all representing measures of relaxation, reduced arousal, and stress modulation. Similar feedback using the electroencephalogram frequency patterns allowed the patient to achieve increased states of alpha, 8 to 12 Hz, or theta, 5 to 8 Hz, frequencies in frontal regions, as well as coherence or commonality between both sides of the brain. Early research in neurofeedback indeed suggested that normalizing brainwaves was uniquely successful in improving or correcting such behavioral disorders, like emotion, attention, or cognition that have disrupted brainwaves. Neurofeedback has been studied in a wide variety of conditions that have in common the disruption of cognitive function, behavior, mood, and emotions, mental health in general, and physical symptoms, especially those complaints suggesting somatization. These conditions have included PTSD and anxiety disorder, epilepsy, attention deficit disorder, ADD or ADHD, minor traumatic brain injury, obsessive-compulsive disorder, depression and mood disorders, autism, migraine, chronic fatigue syndrome, stroke rehabilitation, pseudo-seizures, criminal behavior, fibromyalgia, substance abuse, addiction, and schizophrenia. Research testing the effectiveness of neurofeedback in the treatment of these conditions mostly consists of pilot single case and basic outcome studies. The introduction of functional imaging of the brain through fMRI techniques has allowed us to identify more objectively the effect of neurofeedback on function in selected regions of the brain. fMRI studies generally display those parts of the brain that are selectively using energy at any given time, a measure of which parts are online. Since we know the general role and function of brain regions, we can get a general idea of how neurofeedback might improve brain function in conditions where it has been applied by documenting functional changes in specific brain areas with fMRI studies. Neurofeedback optimally tends to enhance alpha and higher theta frequencies in frontal and central brain regions, as well as enhanced symmetry of wave frequencies on both sides, or what we call coherence. Not surprisingly, studies of brain wave patterns in persons skilled in the art of meditation show remarkably similar patterns of enhanced alpha and hemispheric coherence achieved through neurofeedback. If neurofeedback mimics the therapeutic effects of meditation, it also may explain its effectiveness in what appears to be some of the late manifestations of trauma, both emotional and physical, through the restoration of homeostasis. If it does so by down-regulating the amygdala through enhanced function of the anterior cingulate cortex, ACC, as noted previously, then I believe neurofeedback along with meditation is providing the essential ingredient for the healing of trauma.
I wonder, Jacob, as I reflect over the last 10 years of working with this illness, it's interesting. All of this started for me from a purely sort of theoretical standpoint, trying to work out what is going on with this illness, and it led to my recovery and then to helping others. But along with that, you come to certain conclusions based on logic and science, and then it's interesting how experience can sometimes have a different outcome than theory. And so I wonder, as you reflect over your last 40 years, and perhaps the last 20 years in particular, were there certain things that you used to think or beliefs that you've had about this illness and recovery that have changed?
Well, it's more getting bigger and bigger pictures of that. You know, it's like the 5 blind men and the elephant story. It was like, well, it's a tree trunk. No, it's the snake. It's, you know, and it used to be, oh, it's candida. No, it's adrenal. And I would keep launching into these different areas that each would help somewhat. It's a synthesis of all of those to get to see the bigger picture. That's really what's been changing. But the nice thing again, what I'd like to do, because there's 3 studies that we've recently completed that were, in fact, one of them, I just did the analysis of the initial data right before I got on with you, so you'll be the first person to hear the results if you like. That can be very helpful in optimizing energy and optimizing how people feel overall. So we talked about the porcine serum extract, and the name of that is called Recovery Factors. It's available from Europe. The website is www.recoveryfactors.com. 60% of people who took that improved with an average, in that group, 69% increase in both overall quality of life and energy. We just finished a study of 188 people of I happen to have a bottle here because I take it myself if I have a busy day. It's called HRG80 Red Ginseng. You can get the one for sexual function. The rest is 18 different ones, or 4 different ones. I would just get the chewables, the chewable capsules. They're tasty, don't have sugar. If I have a busy day where I feel like it's swamped, I'll take one. I feel my energy goes right up. We just looking at the data of what we found is, again, about 60% of people improved. And what we saw, I don't even remember the data because I just did it, energy went up an average of 47%, cognition improved 32.6%, overall stamina increased 45.5%. That's with one simple low-cost pill a day. This doesn't have to be massive things. Simple things can make a big difference. But again, start with sleep, to the nutritional support. I'll start with the vitamin powder, so you do 1 drink instead of 50 pills. There's just, let it be organized. We have tools that'll help organize that for people. There's actually a free online program they can do that'll analyze their symptoms and tests. And
help you focus your treatment.
Are in that case.
Yeah, that's a great thing, because when people feel a bit lost, it's overwhelmed, and there's so much to treat because so much is wrong. But ultimately, I always say the best treatment is recover from the syndrome as a whole. So it's there for morale, but it's a little bit more than that. I think it's actually neurologically important for neuroplasticity to occur. And probably the best way to explain that is because there's really a third neurotransmitter at work. And that neurotransmitter is dopamine. So many people have heard dopamine. It's like the reward neurotransmitter. That's how often it's how it's described. But dopamine actually is involved in a whole range of functions, including autonomic function. So, regulating your heart rate, your kidneys, as well as attention, pain processing. Right? And so what happens is you do some positive things. It's like feedback to the brain that you're on the right track. And this is, again, why I will talk about in the program about building recovery momentum. Why we want to have some positive experiences. Because you're doing something and it's working, of course you're going to be more motivated to keep going, right?
Yeah, definitely.
So that's sort of from just the logical, common sense way of looking at it. But neurologically, what dopamine does, dopamine actually acts as I understand it, as like a down-regulating force for noradrenaline. Right? So if you need noradrenaline doesn't downregulate itself.
Right, okay.
So it's like out of control. That's probably why people feel so wired.
Right.
You know, tired and wired.
Tired and wired, yeah, for sure.
Most hormones will actually down-regulate. So the brain and the body will go, hey, this hormone is like, we've pumped out too much of this. It sees that, right? And it says, okay, I've got to reduce the amount of this hormone. This doesn't happen with noradrenaline. And so, and then what's it going to lead to? That's going to lead to like a burnout, if you like, and there's only so much noradrenaline
Right.
you can deal with, right?
Yeah.
And so in order to sustain your focused effort, dopamine will actually bring that noradrenaline down, and it will balance this to allow you to have sustained focus. So dopamine is the third, I'd say the third important neurotransmitter that really allows this process of neuroplasticity to be sustained.
So by engaging in something that we find joyful, we can allow the body to create that dopamine response to do what you're explaining.
I think so, absolutely, and you know, like I think it creates at least the environment for that to happen.
Right.
Yeah.
Right.
I mean, ultimately, I think what we really want is that strong reward. You know, like I'm doing the brain training, and I'm getting better because now you've got that connection.
Right.
And the dopamine hits right, connected to that process. And I think that is very, very powerful. And this is why sometimes we see this, you know how we spiral down over the years with this illness?
Yeah.
This is why sometimes people spiral up, right? So once they start and they get some recovery momentum, sometimes it's a bit tricky for them to get started.
Right.
In my experience, many people, there's things that stop them sort of getting going. But once we get going and we see it's working, it kind of snowballs.
Some momentum. I remember that feeling.